Good morning, everyone. Oh, come on. We got to do better than that. Good morning, everyone. Much better. We'll give you more coffee as the day continues. Good morning. My name is Alejandra Rincón. I serve as Assistant Vice Chancellor and Chief of Staff for the Office of Diversity and Outreach, proud sponsors of this event, and Professor of Family Medicine. It is my pleasure to present our next panel. And so in order, I will present the speakers for this next second block of our session today. Dan Kabella, who will speak to us on AI opioid prescribing, racial disparities, and decoloniality. Second, Taylor Cuffaro and Thye Peng on the impact of syndemic conditions on polysubstance use among sexual minority men who use alcohol or stimulants. Thank you for being here. And last but not least, Shah on disparities in access to dental care. Please welcome our first speaker. Thank you.
All right, good morning. So my name is Dan Kabella. I go by gender-neutral pronouns, so they, them. And I'm an opioid industry documents archive postdoctoral fellow. And before I begin, I just want to say that most of the presentation today will be read by a script, which I use as an accessibility aid for speech accommodation. And I say that because although my gaze may be lowered, I'm deeply committed to this work, and by extension to you all as an anti-racist community of practitioners, and that I'm approachable, so please ask me questions and come talk to me. In this talk today, I'll present on 3 parts. First, I'll give background on proprietary algorithms and discuss the ways they incorporate personal data from vulnerable communities without explicit consent. Second, drawing on critical race and post-colonial theories, I will connect the implementation of these technologies to colonialism and racial capitalism. And finally, I'll discuss the implications for AI-enabled tools in clinical decision-making in the context of opioid prescribing. First, a little background. So in response to the overdose mortality, US states are adopting proprietary algorithms into prescription opioid regulatory frameworks to stem the excessive rate of prescribing. Rather than being directed at pharmaceutical corporations, these algorithms output and embed individual risk scores into electronic health records and are used to determine treatment options for pain patients. Risk prediction models rely on data sets comprised of prescription histories, criminal records, sexual trauma histories, and insurance status. And despite the fact that these data sets are extracted from structurally vulnerable communities, decisions about data access and model design are driven by industry stakeholders without input from affected patients. So for my analysis, I'm drawing on Annabel Quijano's theories of decoloniality, which he defines as a mode of reasoning, an act of delinking from contemporary legacies of coloniality. Coloniality is understood as an enduring process of established patterns of power, owning to colonization that reproduce hierarchies of race, class, and gender. Decoloniality then is delinking from knowledge and value systems instituted by colonialism and the ethics they evoke, so ethnocentrism, sexism, and racial capitalism. In the context of public health, this implies decolonizing all features of modern medicine, from curricula to clinical practice to policy to organizational structures and technologies. Delinking is not enough on its own, however, and it also requires a relinking, in this case, to patient knowledge and lived experience of opioid risks and alternatives for safety. Decoloniality, then, provides us with useful conceptual tools to interrogate the coloniality of opioid prescribing as this emerges from advanced technologies like AI. So, how does coloniality feature in an algorithmic clinical decision-making system like this data analytics platform here? This is NarxCare, which is marketed as a clinical decision support system intended to help clinicians analyze controlled substance data collected from state-managed and regulated prescription drug monitoring programs. On the front end, it appears neutral in the ways it efficiently aggregates data into these risk scores. However, the software engineering practices are not neutral. For one, the algorithm is proprietary, so we don't know how it arrives at these scores, and it's unregulated. It's deployed in healthcare, designed in the interest of efficiency and corporate accountability, but may fail to facilitate human-centered care. Moreover, the opioid industry advances AI's role in opioid prescribing through narratives of prescription safety and responsible prescribing. My research then focuses on the relationship between technology, opioid industry, and governance, and the initiatives that subject people in pain to increased surveillance as a response to the overdose crisis. Specifically, how proprietary algorithms like NarxCare can disproportionately harm protected classes and even exacerbate health inequalities. Algorithmic bias can manifest in everyday life by sectioning large populations of people in pain who will not receive care, potentially driving them into illicit opioid markets with even greater harm. Research documenting sources of data used without patients' consent outlines these concerns. So legal scholar Jennifer Oliva writes, the proxies that NarxCare algorithms utilize as risk indicators, such as patient criminal histories, sexual trauma histories, numbers of prescribers, prescription payment methods, and distance traveled for treatment, are problematic on their face and likely discriminate against marginalized patient populations, including individuals with complex chronic pain and opioid use disorder who live in poverty. To study AI, coloniality, and NarxCare, I use an established set of methods known as industry documents analysis. Drawing on internal documents found in the Opioid Industry Documents Archive, which is part of a larger web-based archive here at UCSF that includes other industries like tobacco and fossil fuels, as well as food. So in this document, the FDA's Opioid Policy Steering Committee held a public hearing in spring 2018 to get input on proposed prescribing interventions and strategies to implement them. One strategy they proposed was a database that would be designed and implemented across state lines. The private company Bamboo Health, producers of NarxCare, suggested here in their public comment access and use of court records to be added to the database so that this data could be used as their patient risk prediction model to predict the likelihood of opioid abuse and diversion. People with criminal records then would have high-risk scores, subjecting them to increased surveillance and potentially denial of opioids. This demonstrates how racial capitalism that undergirds the mass incarceration campaigns imprisoning majority Black, Brown, and Native people in the US on nonviolent drug-related charges now reemerges as a component of individual risk if that same person previously targeted for criminalization at one point in their life is in need of pain management at a later point. These structurally produced disparities are not confined to isolated data sets, but are being codified into laws. In this next example, major opioid distributor McKesson Corporation links NarxCare to the company's safety initiative as a way to address regulatory restrictions of available opioids. In a white paper, they propose NarxCare as a solution to essentially weed out the less than 10% of patients at risk. According to the proposed legislation, analyzing and leveraging prescription transactions, or the ALERT Act, industry-sponsored nationwide prescription safety alert system would require pharmacies to release prescription history data extracted from pain patients to receive shipments of opioid medications. Industry leads the design of risk mitigation of their own products, and here the intervention is proposed for mitigating risky patients rather than risky products. Characterized both as risks to public safety and individuals in need of pain relief, patients often are targeted of these technologies that closely monitor their actions. And as we learned from the previous example, risk scores are skewed across race, class, and gender lines, making them the 10% who may not receive pain medication. So putting these findings into conversation with existing literature, like Ruha Benjamin, a Black studies scholar and foremost thinker in race and technology, offers a generative concept, technological benevolence, to help us recognize how technologies that are developed to benefit humanity often reproduce oppressive and discriminatory societal structures. Applied to NarxCare's role in opioid prescribing, we can see how government bodies, the opioid industry, and the health tech industry promote NarxCare as an efficient fix to the opioid epidemic without acknowledging the racialized disparities that could result from its targeted predictions. With one more minute to go, so in conclusion, NarxCare is presented as a benevolent technology under the industry's rhetoric of patient safety, allowing it to advance AI for the overall good of society, yet NarxCare has perpetuated harm because it excludes lived experience practitioners in algorithmic design and implementation. So we recommend that decision makers cultivate decolonial ethics in the development and uses of AI in opioid prescribing by linking with data justice in the interest of the public and people most affected. This involves creating communities across clinical practice and pain patients that work to build a foundation for contesting, redressing, and reversing algorithmic coloniality. Doing so can shift the decision-making power away from the proprietary hands of private industry to affected communities. Thank you.
Hello, my name is Taylor Cuffaro. Let me get here. And I'm joined by my colleague, Thye Peng No. My pronouns are also they, them. Oh no. And I also will be semi-scripted today, but am approachable, so please do come chat. So we wanted to acknowledge Dr. Glenn Milo Santos for his mentorship and also giving us access to the study data, and we have nothing to disclose. So today's, oh, sorry, that's you.
All right. So today's objective is to provide an overview of the syndemic theory. How do I do this?
The big one.
Oh, okay. And we'll talk about our syndemic study on multiple substance use among sexual minorities and give you some implications and takeaways. So I'll talk briefly about the syndemic theory in case you haven't heard of the theory. So Mira Singer is a medical anthropologist who coined the term syndemic, which came from the word synergistic, epidemic, pandemic, or endemics. And Singer described the theory as having two or more co-occurring biopsychosocial conditions that synergistically interact and increase negative health consequences in a population. I think it is important to understand that it's not just the co-occurring conditions, but the actual synergistic interaction. And we call that multiplicative effect. This theory has been applied in many public health studies, including this one here. They call it the SAVA studies, which is one of the first and most influential cases use syndemic theory. So this is just a picture to depict what I just explained. Syndemic factor 1 can co-occur with syndemic factor 2, and that potentially increased the risk of negative health outcomes. For example, we know that substance use and mental health tend to co-occur, and they also interact with each other that amplify, for example, here, the risk of HIV infection. So we are very interested in the outcome of multiple substance use. So multiple substance use is defined as the use of using two or more substances from multiple drug classes, either concurrently or simultaneously. It is very prevalent, unfortunately, among sexual minorities compared to the general population. And multiple substance use is associated with many adverse health outcomes, including sexual risk behaviors, injection drug use, and also high mortality compared to monosubstance use. Multiple substance use in sexual minorities is driven by many intersecting factors, including health, psychosocial, and structural factors. However, there are limited studies focused on multiple substance use compared to monosubstance use in the context of syndemic among sexual minorities. which prompted us to do a secondary analysis to examine the syndemic factors associated with multiple substance use among sexual minority men in the United States. Specifically, we want to examine the prevalence of multiple substance use by the number of syndemic factors. And then we wanted to determine if a greater number of co-occurring syndemic factors are associated with the high odds of multiple substance use. And finally, we identified the top 3 co-occurring syndemic factors that have additive and multiplicative effect, on multi-substance use. Now, Taylor will take over talking about the methods and results.
Great. So this is a secondary analysis of baseline survey of sexual minorities in the US. Our N was 148. This clicker's wild. So the outcome, we're looking at self-reported monthly multiple substance use over the last 6 months, and we included all the fun stuff minus tobacco. So alcohol, stimulants, opioids, benzos, party drugs, marijuana, poppers, and hallucinogens. We chose 5 syndemic factors to analyze, and these were chosen based on the literature, clinical expertise, and of course, a statistical analysis of all the syndemic factors available in our parent study. We looked at self-esteem, we looked at depression, HIV status, and/or diagnosis of an STI in the past 6 months, and experiencing discrimination using the Everyday Discrimination Scale, and we also looked at the experience of houselessness. So to understand the cumulative effect of syndemic factors, we created 5 categories. Someone had none, 1, 2, 3, or 4 or more syndemic factors. We used a multivariable logistic regression, controlling for age, race, ethnicity, and education. And we also used a dose-response analysis, looking for log linear and quadratic trends. Our exploratory analysis looked at the additive and multiplicative effects of 3 co-occurring syndemic factors with the highest odds of multiple substance use. And please excuse my typo here, that should say MSU and not HAC. So here's some results and characteristics. Demographics, a mean age of 34, 24 folks identified as racial minoritized community members, 20 identified as Hispanic or Latine, and 53 reported multiple substance use over the last 6 months. And the prevalence of syndemic factors are as follows. 13% had low self-esteem. Interestingly, more than 50% of our folks were experiencing depression and/or discrimination. 10% were positive living with HIV or had been diagnosed with an STI in the last 6 months, and 17%, just over 17%, were experiencing houselessness. So let's talk about the prevalence of multiple substance use. When we looked at the prevalence here by number of co-occurring syndemic factors, we found a statistically significant positive log linear trend. So as the number of syndemic factors increase, we expect to see the prevalence of multiple substance use to increase as well. And here we see the odds ratios for multiple substance use by number of syndemics. As you can see, 3 and 4 or more syndemics carry markedly high odds ratios, with 9.6 times the odds of multiple substance use when you're living with 4 or more syndemic factors compared to someone without any syndemic factors. And the 95% confidence interval, I'm sorry, isn't listed here. For the 3 syndemic factors is 1.05 to 8.40. For the 4+ syndemic factors, the 95% confidence interval was rather wide at 1.92 to 47.54. Likely some of that is because of our small n. So for our exploratory analysis, we looked at the additive effects of syndemic factors to find the 3 most impactful co-occurring syndemics. You'll see here the co-occurrence of houselessness, depression, and discrimination are found to have more than 6 times the odds of multiple substance use. Houselessness, depression, and STI or HIV or STI in the last 6 months had a 10.5 times the odd and was approaching statistical significance. It'd be interesting to see what a bigger population would show us there. And while these co-occurring syndemic factors are interesting on their own, we were particularly curious about the impact of interacting syndemics. Here we see the top 3 interacting syndemic triads affecting multiple substance use. The most significant triad here is low self-esteem, depression, and HIV positive or an STI in the last 6 6 months, which increased the odds of multiple substance use by 2-fold. And this is particularly interesting because these syndemic factors are interacting with one another. When you target one, you're going to see an effect likely on the others. And so this is really powerful for us when we're thinking about interventions and what to do about multiple substance use. So of course we have limitations. Our biggest limitation is that the data did not differentiate between sequential and simultaneous use. And certainly using multiple substances at the same time compared to using individual substances over 6 months will affect the risk for morbidity and mortality associated with multiple substance use. So we'd love to see what it would look like if we only looked at people who were using substances at the same time and compared it to sequential use. And we had a small sample size, and the majority of our folks were sexual minority men. So we'd like to see that be broader. Implications and takeaway, there's a lot of room for addressing multiple substance use, but we need to take an interdisciplinary approach, and we need to be multi-level to consider the person, the social, and the structural. Thank you so much.
Is Shah here in the room? Jay, please come forward. Thank you.
Okay, so my research pertained to dental public health. It was a project that I worked on in my second and third year. I'm a fourth-year dental student, and I did research under Dr. Bonava. She was my principal investigator, so this study would not have been possible without her, despite my name only being on the first slide. She was very instrumental in this whole project. So the title of my research is Disparities in Access to Dental Care During the COVID-19 Pandemic, an analysis of the Rapid SF survey. Some of you guys may be familiar with that survey. If not, I'll get into it. How do you do this? Okay, so background. Obviously we all know that multiple factors can influence dental care, such as socioeconomic status, race, ethnicity, language spoken at home, education level, and emergencies such as the COVID-19 pandemic. And then in March of 2022, the Stanford Center on Early Childhood conducted the Rapid SF survey entitled Maternal and Adolescent Community Outreach During the COVID-19 Pandemic. It wasn't just conducted by Stanford University, the San Francisco Department of Public Health. They were also involved with this. And I would say they kind of took on the survey, the title I believe came from them, but it started from Stanford University, so I guess they get the credit. It was an extensive survey and to explore the healthcare and financial challenges faced by families in the San Francisco Bay Area during the pandemic. And one topic they investigated, obviously, was the accessibility of dental care for San Francisco families. Study design, our goal was to evaluate the survey results and identify potential barriers to dental care during the pandemic. Obviously, we're assessing the impact of COVID-19, but we also want to look at demographic factors such as race, ethnicity, household language, education level, insurance coverage. And then we introduced a new variable called low income, which was really supposed to be a proxy for socioeconomic status based on eligibility for Medicare, Medicaid, free reduced lunch, and or food stamps. And then the outcome of measure was past year dental visits. So that was kind of our measure for dental care access. So methods and materials, the rapid SF survey was conducted in 2 phases. The first phase included 3 baseline surveys conducted during the following periods. It was baseline 1, baseline 2, baseline 3. And then the second phase consisted of 3 follow-up surveys. There's over 150 questions in total covering a variety of things. So obviously kind of the race, ethnicity, language. But in addition to that, there's also childcare accessibility, healthcare availability, child nutrition, education, parental employment, COVID-19 related questions. So we reviewed all the questions. It was a lot, but we reviewed all the questions and we extracted those that were related to dental care access and related study variables. And then we performed statistical analysis with SATA software. So here are the questions that we're really focused on. Obviously, the first 2 questions pertain to race, ethnicity. So we get that. And then also education level, so highest degree of certification you earned, yada, yada, yada. And then what type of health insurance does your family have? Do you currently use any of the following, food benefits? And then since the COVID-19 pandemic started, has it been hard for any of your children to see a dentist? Yes or no, and why? And then, okay, so our results. We only analyzed the baseline surveys because unfortunately the follow-up surveys were, follow-up surveys had a very low respondent number. So that was disappointing, but it's just the reality of conducting surveys sometimes. And then we conducted a descriptive analysis first of past-year dental visit frequency in relation to race, ethnicity, language spoken at home, insurance type, education level, and then low-income status. And then we performed a logistic regression analysis to identify like association between past-year dental visits and study variables. So this is a descriptive analysis. It's very difficult to understand. I was showing it to a few of my classmates yesterday, and they had no clue what was going on. So, I color-coded it. Obviously, each color represents a different study variable. And then I'm going to get into, in subsequent slides, I want to get into like the details. So I have important information in bullet points. The first two bullet points are bolded because they really actually, refer to the overall table, like the overall descriptive analysis table, not just like the smaller tables that I have. So the percentages of past-year dental visits are actually in parentheses. The number in front of the parentheses is actually the number of respondents who had a past-year dental visit. So it's not the total number of responses for that group, it's just the number of people that had a past-year dental visit. Okay, so, and then most respondents were in the first baseline group, and you kind of see that looking at the bigger table. So that's where a majority of responses came from. So in terms of race ethnicity, Asian was the largest racial group. On average, Asians also had highest past-year dental visit frequency, followed by whites. So when I say that, when I say past-year dental visit frequency, the wording could have been a little bit better. I'm really talking about percentage over all three baseline groups. So I just, averaged them, and Asians, I believe, had the highest, followed by whites. And then in terms of language spoken at home, English is the most common language. That's not surprising. And then on average, English and Cantonese speaker had the highest past-year dental visit frequency. And then in terms of insurance type, employer-provided insurance that's the most common insurance type that people had, and people with that insurance had a much higher past-year dental visit frequency, again, referring to percentages across all three baseline groups. And then education level, bachelor's degree is the most common education level, and families with members holding associate's degree or higher had much greater past-year dental visit frequency. You could almost draw a line between some college and associate's degree, and you see kind of a drastic change going from one to the other. People who have specifically like less than high school, some high school diploma, much lower past-year dental visit frequency percentage compared to people with an associate's degree or higher. And then lastly, that low-income variable, most families were not low-income. It says people, it should say families, I'm sorry about that. Not low-income families had a higher past-year dental visit frequency. And then here's a graphical representation of the descriptive analysis. It's kind of repetitive. I included it because, this is something that we kind of included in our research paper, but I'm going to skip it in the interest of time. So challenges to dental care during the COVID-19 pandemic. So this was actually pretty surprising. If you guys read it closely, most families were actually able to access dental care during the COVID-19 pandemic. In fact, over 50% said that they had no problems whatsoever. Let's see, what else? So 70% of people said that they did not face any challenges, and 17% of them said, was it 70% or? Oh, I'm sorry. It wasn't 70%. It was like 66%. Said that. So 53% said that no, they had taken care. That's a majority of people, majority of respondents. And then 13% of them, I believe, said that that dental care was not needed. It was not necessary during the COVID-19 pandemic. So they didn't face any challenges because of that. And then here's the logistic regression analysis. It's kind of like the descriptive analysis table. It's just a lot of numbers. The reference categories that we had for each variable for whites, for race ethnicity, white was the reference category for language, English was the reference category for education level, master's or a doctorate degree, that was the reference category, insurance type, employer provided insurance, and then low income status, not low income was referenced. So those are our references. And then if a p-value was, if it was significant, if it was less than 0.05, I bolded it. So I want to skip to the next slide just to kind of give you guys a summary of the findings that we had from the logistic regression analysis. There's lower educational attainment. There's an association between lower educational attainment and dental visits. So individuals with less education, specifically less than a high school education, showed a much lower likelihood of visiting a dentist. Families with Medicare, Medicaid, healthy SF, private insurance, or multiple insurance type, essentially anything outside of employer-provided insurance, were less likely to have a dental visit. And the low-income families, unsurprisingly, unfortunately, were less likely to visit a dentist compared to their higher-income counterparts. Conclusion, just 3 points quickly. So just three takeaways for this presentation. Addressing disparities in dental care access necessitates a comprehensive approach. Strategies should prioritize dental health education, expanding insurance coverage, that's a big one, and then ensuring healthcare service resilience during emergencies. And then continuous research is essential to assess the effectiveness of interventions. This is just kind of like an understanding of the different barriers, but we need more research to actually investigate interventions. And then especially among underrepresented and vulnerable populations. And that is it. Okay, thank you.
Okay, I'll bring all the speakers to the podium. If you can just join us here. Thank you. This was wonderful. Thank you all. Yeah, please take a seat. We'll have microphones moving around. Great, and we will welcome questions. We have about 10 minutes for questions, so just raise your hand again. Brooks, there's one here and another one back there. And we might take one or two at the same time just to give the speakers just a second to think about their answers. Thank you. Please identify yourself. Thank you.
Okay. Hello, my name is Mira Sir. I recently graduated from UC Berkeley with my BA in Public Health, and now I do research at UCSD at the Center for Medicinal Cannabis Research. And this question is for Dr. Kabella. My question was, with your research, you were kind of investigating how these companies are kind of trying to incorporate information about people's kind of like the social determinants of health, like their kind of lived experiences and their experiences with like the legal system and all of that into kind of these algorithms that determine whether they can get a prescription for opioid medications. And I wanted to ask, what the, I guess, legal landscape around these algorithms is, because I know there's laws that are designed to help protect patient privacy, like there's a whole like right to privacy in the 14th Amendment, there's like GINA for protecting your genetic information, HIPAA. Like, is there anyone who's kind of trying to, use these laws or trying to like develop laws to protect the privacy of this information so it's not being used to discriminate against people?
Do you want us to take another question before you answer that, or you ready? Yeah, I can. Okay, go ahead. If you can speak to the microphone, please. Thank you.
First of all, thank you for that question. Yeah, the answer is there are. And I don't know a ton of the cases. I don't have a legal background. I'm a social scientist, but I did find one that it was actually around information about trans health. Actually, that so the PDMP is a database that collects information on controlled substances. So people who are taking like testosterone or estrogen also is part of the PDMP. So I did find a few cases that people were pushing back against information using in that case. But as far as opioid, as far as like pain patients, I didn't see any. That to say, there might be some out there, I don't know. But it might be a much stronger front than it just being focused on pain patients, but all people whose data is being used in these algorithms might be something to consider. I quoted her, but Jennifer Oliva is a legal scholar who was a visiting professor here for a while. I don't know if they're still here, but they do a lot of really great work around that, and I'm happy to pass along some information if you'd like, but thank you.
Great, thank you.
Hello. Thank you, Dan. Dan is my colleague at the Tobacco Center. It was a very interesting research and talk. I was wondering if doing, I'm just curious to know if you agree with this, that it would be good to do a clinical trial comparing the NARCs, was it NARCs, I suppose, and the medical doctors alone, comparing medical doctors' decision-making with the support coming from NARS, because I'm just thinking that medical doctors can be even more biased and non-inclusive or stereotypical when it comes to prescription, for example, prescribing for people with the kind of backgrounds that you talked about. Is this a good question, do you think? Thank you.
Yeah, thank you, Merdad. Yeah, I think that, I think there's a difference between like individual bias and like structural bias. What I was trying to present on is more of a structural kind of bias, the things that clinicians might not be aware of that are built into these models. So, it may not be the clinician or the pharmacist who's intentionally trying to bias someone, but they just don't know. They're just, faced with these algorithms, these risk scores on their screen, and they have very little time to see patients, so it's a very efficient way to be like, oh, you have a high risk score, then I won't give you an opioid. So without thinking about what goes into it or who's in front of them, it kind of depersonalizes the interaction. So I think the better question would be to see how clinicians interact with this technology and maybe how they're imagine the technology being an aid or something that is not a good thing to have in their clinical practice. But although that doesn't mean that people aren't inherently biased, but that's not the work I was trying to do here. Thank you.
Thank you. Other questions?
Hi, my name's Ellie Picasso. I'm a fourth-year medical student in the Prime US program and also have my MPH in health policy. My question is for Jay Shah, focused on the dental work. I was wondering if you were able to dive more into the fact that there is a lot of dental carve-outs in Medicaid due to active lobbying against covering dental care in Medicaid and how that interacts with folks being able to access this care, seeing as I'm not sure how the survey was distributed and how and generally just a lot of folks get dental care through private insurance. So I was wondering if there was more accessibility and equitable discussion in terms of why some folks may not be able to access, if they're on public health insurance models, this dental care that is so needed.
So I would say that individuals with Medicare, Medicaid, public insurance, they tend to not be able to access dental care as often. Usually it's due to the lack of coverage by those insurance, by those insurance plans. Usually private insurance, they'll provide coverage for larger number of services. Also, even if there is no difference in terms of like the coverage, individuals with private insurance, they tend to, they're higher socioeconomic status, so they can still afford dental services. And then also, I would say another thing is just like oral health literacy. A lot of the people who have that insurance, they tend to be, the Medicare, Medicaid, like Medi-Cal as well, they tend to have less education. They don't understand oral health as well. So that kind of feeds into it as well. Does that answer your question? Or I couldn't hear.
Please use the microphone for accessibility. Thank you.
Thank you. Partially, I think it's the question I do want to reframe against folks having low health literacy that could be due to like background that we don't know about. And so just focusing more on the health policy aspect of like, are you hoping that this research will change a lot of the lobbying efforts at the ADA in terms of folks being able to access dental care who are not privately insured?
Yeah, I mean, that's definitely like one of the like ultimate goals of research like this, all dental health public research. The point of it is to increase equity within the world of dentistry. I think that unfortunately, there are a lot of sad cases that I've seen personally as a dental student in the student clinic, where individuals, because they don't have access to dental care, they wait to the last minute, and then as a result, they're forced to, get like half their teeth extracted, or, like they have to get treatment that they would have been able to avoid had they been able to, afford dental care. So yes, definitely like that was one of our like significant findings, that individuals with Medicare, Medicaid, they had, less, and, obviously like other insurance types, they had less access. So hopefully, within the state of California and also just like across the country, this study can be used, to bolster, expand insurance coverage and also ultimately bolster dental care access.
Great. We have 1 more minute for one additional question. Quick, thank you.
Is it on? Okay. Hi, my name is Juanita Green. I'm here representing Stanford Reach Lab, where we develop comprehensive drug education. So I really appreciate you guys' presentation, and I love the intersection between substance use and sexual health outcomes. My first question was that why you guys did not include tobacco use or nicotine use in your study, and do you find that low self-esteem and depression and sexual health outcomes kind of interconnected? So does someone who has HIV, does that decrease their self-esteem, or does that increase their depression? How do those things interact with each other and kind of are interconnected?
That's the question, I think, that last question, right? Like, how are those interacting? Why are they interacting? And where is our best entry into intervening? What the secondary analysis did what the secondary analysis says that we did is you have to look at these 3 things. You need to go deeper into this. There's a connection here. You get at one, you're going to get at the others. But which one and how do we get to all 3 is the question. So we'd really love to do a primary study looking at this. And self-esteem, interestingly, was on all 3 of our most influential triads. And it's something that I have a colleague and mentor. I'm a street medicine provider outside of this. And I have a colleague and mentor who's always talking about shameosis is what she calls it, right? So that's, we all there's all this shame, right? And so how do we address the shame so that we can get to health? And I think that this analysis tells us that we do need to care about self-esteem, and certainly we need to look at how does HIV or STIs interplay with esteem and depression, since those 3 are so at play for the outcome of multiple substance use. We were limited in our syndemic factors and substances by the parent study, but certainly looking at tobacco would be interesting too. Yeah, thank you.
Thank you. On that note, let's give them a round of applause. Thank you so much. Thank you. We'll get ready for the next set of speakers. Before I do that, I want to thank the leaders from the other schools and the cabinet who have joined us today, Dr. Sharon Newman, School of Pharmacy, Dr. Mika Estrada, School of Nursing, Vice Chancellor Dan Bernal, Community and Government Relations, and Vice Chancellor Guan, who I see just arrived in the audience. Thank you for joining us. It is my pleasure to welcome the next set of speakers. We are going to share a bit of a new innovative partnership between UCSF and the San Francisco Unified School District, known as the Mission Bay Linked Learning Hub. This partnership is to bring true our desire to be a better neighbor to the San Francisco Bay Area and to offer more opportunities to underrepresented students, hosted and sponsored by the Office of Diversity and Outreach. It is my pleasure to welcome my colleagues from the ODO, Jessica Sanchez from the Center for Science, Education and Outreach, and Michelle Guan, who will be presenting on the Mission Bay Linked Learning Hub. Welcome.
This is the clicker. Yeah, okay. Is this the clicker? Okay. Perfect. Welcome, everyone. Thank you so much for the opportunity to talk a little bit more about some great work that we're doing here at UCSF in collaboration with the San Francisco Unified School District. And so with that, all right. So we're happy to talk a little bit more about the Mission Bay Hub. All right, so for those of you who may or may not have heard of the Mission Bay Hub, this is a, as Dr. Rincón mentioned, this is a brand new innovative partnership that we have with the Mission Bay, with San Francisco Unified School District. And so essentially the Mission Bay Hub is a interdisciplinary project-based model with a health and life science focus. And so this opportunity and this idea really stemmed from the idea of really helping diversify science, STEM, health and life science. And so what makes this program very unique is that students are essentially here in Mission Bay really exposed to the diversity and the variety of opportunities that we have as a university to really connect them with those opportunities. And some of those opportunities look like in the form of a brand new near-peer mentorship model that we incorporated this year. And so we are currently working with 6 different students in the professional schools that are really providing students with mentorship around helping building their college and career going identities with the hopes of inspiring some of our next generation of students that may be interested in going into STEM. And then in addition to that, the program also provides students with a 5-week internship that happens in the spring. And so students are in a different department across UCSF that are providing students with a very explorational experience to help them really understand like what are the different careers and different opportunities that they can get involved with after their time in high school. In addition to that, we also coordinate site visits for students to go and see some of the things going on here at UCSF. And we also welcome folks to come and talk to students in the form of guest presentations and really share a little bit about their work. Again, the intention behind this is to really help students understand the diversity of opportunities that can happen after high school and really helping them prepare for that, considering that our target audience of students are 11th and 12th grade students. Also, another notable thing to mention is that the Center for Science, Education and Outreach is the anchor partner within this partnership. And so many of the opportunities that we connect students with are directly connected here at UCSF, in which we're very, very proud of being able to provide students with those opportunities.
Thank you, Jessica. Hi, everyone. My name is Michelle Guan. I'm the head counselor with SFUSD's Mission Bay Hub program. And alongside what Jessica had shared, we partner with 5 high schools in San Francisco Unified School Districts, Thurgood Marshall, June Jordan School for Equity, the Academy at McAteer, Mission, and SF International High Schools. So we work primarily with 11th and 12th grade students, and this year we have a total of about 50 students. We have a group of students that come in the morning, so they actually come to Mission Bay. They take classes at Mission Hall, Byers Hall, Genentech Hall in different classrooms. So if you've been around and you've seen high school students walking around and you're a little confused, those are our high school students in the district. And then what those students in the morning, when they come to Mission Bay, they take their science, English, and a college and career elective class with us. Then they actually get bused back to their home sites to finish the rest of their day at their home sites. Then in the afternoon, we have another set of students who start off at their home sites and then they find their way or get bused over here to finish their afternoon at Mission Bay with us. And then during that time that they're here with us at Mission Bay, they engage in all those opportunities that Jessica had shared with our UCSF partners. And we will be opening up a new facility in 2026. So if you've seen construction near like the soccer fields area where the elementary school is going to be open, we are actually going to be occupying the top floor, so the 4th floor of that building.
Yeah, so we're actively looking for different departments, different individuals here at UCSF that have an interest in working with the high school population. And so we'd love to, you know, as an open invitation, if there is any interest or if anyone is actually has any particular questions that, you know, you would like to go a little bit more in detail with us about, we're also right outside. We have a table where we're more than happy to answer any of those questions. But also for the sake of time, this is the 2 QR codes are some of the opportunities where we can collect some of your information and follow up with you in case there is any particular interest with your department.
Thank you.
Thank you.
Thank you. We have about 10 minutes for questions for Jessica and our other colleague, Michelle. Any questions on this new project at UCSF? Yes, Jen, and there'll be a microphone coming. And if there's anyone else with a question, you can raise your hand so we know where to take the microphone. Thank you.
Thanks so much. That was great to hear about. And I don't know if this is a question for you or for like UCSF, whoever UCSF is, but I noticed that 2 of the high schools on your list are ones that are potentially closing. And I was just curious if and how UCSF, as the 2nd largest employer in the city, is advocating to keep schools open or being involved in that discussion.
Is it on? Wait, can you hear? Okay, thank you for that. Just a little bit of personal information about myself. I was actually the counselor at June Jordan for 4 years prior to joining the team at Mission Bay Hub this year. So it actually comes really close to my heart with the school closures. So I really appreciate you for bringing up that topic. In regards to the question around UCSF's support for the schools that are being impacted, because the Academy and June Jordan School for Equity are 2 of the high schools that are listed on the potential list for closures and mergers in SF Unified. I will express that we've received a lot of support from UCSF and CSEO in any like forms of rallies, letters of support from our staff at the Mission Bay Hub as well. Like any support that the schools have requested, we've been doing that, attending the rallies, whatever work that you know, they are able to do. In regards to like the overarching UCSF, I can't comment on that, but from my personal experience being at June Jordan for the past 4 years and during this whole entire process, I felt definitely a lot of support from UCSF, especially the partnership with the Mission Bay Hub and CSEO.
Thank you. Any other questions? Yes, Roberto?
Thank you. Very exciting to learn about this important project and opportunity for young folks. And I know you all talked about like internships and other ways that folks across the institution can support the young people. Just wondering if you could speak more to what we can do collectively to support the young folks that are learning in this program.
Hi, Roberto. Nice to see you again. Definitely. So I would say, because this is a fairly new program, one of the ways that we can really use everyone's support is to talk about it. So talking about it across different departments and letting folks know, like, did you know that there's high school students here at Mission Bay that you can actually work with? So that's one of the ways that we actually have been able to come across many different departments is through word of mouth. And so we encourage everyone to uplift that and continue boosting that opportunity. In addition to that, just talk to us directly, and then we can also share any like physical resources as well to really help kind of get the message out. But for the most part, because the program is growing and it's in its developmental phase, we are also very much open to any recommendations or feedback that folks may have, because we understand that different departments may have different strategies for how to share these opportunities with folks that work within those departments. And so we also want to be mindful about how we can also share that information or these opportunities across the university as well.
I would also like to add, I know that there are some folks in here not directly from UCSF or whatnot. I also want to open that opportunity for other partners that are non-UCSF to also reach out to myself because we do partnerships with non-UCSF hosts as well. Although CSCO and UCSF are our main partner sites because they're here in Mission Bay, we also know there's so many more opportunities available for students, and we don't want to limit that. So if that's also something you have contacts with or you would like to reach out, please do so.
Is this on? Oh, yeah. I'm Ada Robinson from Children's Hospital, too. How is this different or similar to the FACES program that's run by Dr. Tomas Magana and also the CHAMPS program at Children's Hospital in Oakland?
Those are good questions. I don't think I can speak on it too much because I'm not too familiar with their model. But what I will say is that really what makes this program very unique is the fact that students are here in Mission Bay, spending either half the day with us in the morning or half the day with us in the afternoon. And so I think proximity, location, we would say is what really makes the program very different, in addition to some of the programming and activities that we have scheduled within the program. Again, that it's really based on location. And so having students here and having different partners come and meet with students and really minimizing the travel, them having to go to one place or another, that's one of the ways that we have really been able to get interest from folks because we kind of minimize that travel barrier in a sense. In addition to that, the students that are also a part of this program are also affiliates of the university. And so that also helps with being able to provide students and that also provides students with the opportunities to really be able to be in certain spaces because we can provide them with any necessary training, any necessary documentation that's needed, considering that they undergo the affiliate process in the meantime that their building is built. And so once they're at their building, that some of that may shift, considering that they will have their own dedicated space for different partners, whether if that's UCSF as an anchor partner or other community-based organizations, other organizations that are interested in working with the program will have that dedicated space where they can come and do some of the programming and activities within the designated space that we will have for them. So.
And the students who are in the program, because they're spending their school day, they're actually spending their school day with us, they're earning their high school credit here with us, and they're all college-eligible courses. Our English class that we're doing this year is actually an advanced English and public health, so students are receiving that additional booster for their GPA if students are interested in applying for your colleges.
Excellent, thank you. Brooks, do we have more time? No? Okay, all right. Well, I want to thank both of you for your work.
Thank you.
And maybe just to add to the last point, beyond the logistics about having them here, is really to start influencing their decision to come here and to see themselves as a place where they can have their future professional identity associated with. So it's just beyond the easiness of having them here. It is now my pleasure to welcome Dr. Catherine Lucey, who will introduce our keynote speaker. Dr. Lucey is a practicing physician and leading national voice on medical school education. She took the helm as our Executive Vice Chancellor and Provost in January of 2023. As CVCP, Dr. Lucey leads both UCSF Robust Research Enterprise as well as its highly ranked academic programs comprising of the 4 schools and the graduate division. And she's standing here very close to me because she wants me to speed this up. She works, if you know her, you know she's all about, getting things done. She works in close collaboration with the Chancellor and the leadership team to develop and implement campus priorities, missions, and maintains the university ranking. She does a whole lot for UCSF. This is not in the bio, but I would say that if you have worked with her, you know that she is a determined leader, a tenacious leader who knows how to get things done, to stay the course, to push the institution forward, and most importantly, a great partner to the Office of Diversity and Outreach. Welcome, Dr. Lucey.
Thank you, Alejandra, and I want to first acknowledge the incredible leadership that our Vice Chancellor Renee Navarro, Associate Vice Chancellor Tong Nguyen, and all of the staff at the Office of Diversity and Outreach have done over my past 14 years here. It's astonishing and very gratifying for me to see how this event has grown, how we have both uncovered and supported interest in advancing the field of health equity and anti-racism research, and also advancing the fields of strong community partnerships that meet the needs of the communities first, and not necessarily the needs of the university. It really is amazing to see what has been accomplished, and I'm really, really grateful for the leadership of the Office of Diversity and Outreach. It's my pleasure now to welcome back the keynote speaker for UCSF Health Equity and Anti-Racism Symposium this year, Dr. Monica McLemore. Woohoo! You can feel the love. Thank you. Dr. McLemore is a tenured professor from the Child, Family, and Population Health Department and the director of the Manning Price Spratlin Center for Anti-Racism and Equity, an acronym CARE, in nursing at the University of Washington School of Nursing. She served as the interim associate dean for equity, diversity, and inclusion in the School of Nursing. She currently holds endowed professorship and lecture in health promotions and is editor-in-chief of the Health Equity Journal. Dr. McLemore's research is focused on understanding reproductive health and justice. She is clearly a woman we need at this time. She is past chair for the Sexual and Reproductive Health section of the American Public Health Association and has published to date 142 peer-reviewed articles, op-eds, and commentaries. Her voice is loud and powerful and so very appreciated at this time of our being. Dr. McLemore's work has been cited in 6 amicus briefs to the US Supreme Court, 4 National Academies of Science, Engineering, and Medicine reports, and a data visualization project entitled How to Fix Maternal Mortality. The first step, she says, is to stop blaming women. This was published in the 2019 Future of Medicine edition of Scientific American. I think that deserves applause. She is also a tremendous communicator to lay public. Her work has appeared in the Huffington Post, Lavender Health, Dame Magazine, Politico, ProPublica, National Public Radio, and she made a voice appearance in Terrence Nance's HBO series, Random Acts of Flyness. Dr. McLemore was inducted as a fellow of the American Academy of Nursing in 2019, the same year she retired from clinical practice as a public health and staff nurse after a 28-year career, most of it here in San Francisco. While she is at UCSF, Dr. McLemore was a champion for health equity and anti-racism research, for rigorous research that addressed questions and advanced and moved the field to policy for benefit of our patients and our communities. She was chair of the UCSF Office of Research Task Force on Health Equity and Anti-Racism from 2021 to 2022. The report that she shepherded eventually led to the creation of the UCSF Office of Research, Inclusion, Diversity, and Equity. Wait, sorry, I got that wrong, and it's my office. It's called the IDEA, Inclusion, Diversity, Equity, and Anti-Racism, position that Dr. Nguyen holds currently. Dr. McLemore also received the 2019 Thomas N. Burbridge Public Service Award given annually by the UCSF Chancellor at Founders Day for exceptional public service promoting equal education and employment opportunities, civil rights, and social justice. It should be clear to all that Dr. McLemore is an exemplary model of a champion for health equity and anti-racism research. Given the pervasive threats to women's rights and women's health, particularly Black and other women of color, I can't think of a better keynote speaker for this year's Health Equity and Anti-Racism Research Symposium. Please join me in welcoming Dr. McLemore. I love the preemptive standing ovation.
People who know me know. Hey, y'all. I see y'all are still holding on to vestiges of things we should have let go of a long time ago. Can I walk around? Okay. And who's got my time? You're Brooks? Thank you. Okay. Can we clap for Brooks? Brooks made sure I got here from, I came from New Orleans, and I'm leaving very early tomorrow morning to go back to Seattle so I can go to Yakima because the public health meeting is there. But you got me here safely, set me up. Thank you very much. I'm very grateful for you. I'm Monica McLemore. I use she and her pronouns. I'm gonna walk around. Wait, let's see. Situation. Oh, yeah. Love it when technology works. It's so good to be back here. You know, I was here, Keith Yamamoto asked me to come and speak at the Precision Medicine meeting that he held where our good colleague, Dr. Alejandra Nelson, for the person who asked the question about AI and the law and privacy, talk to me because I have some ideas for you. Wow, did that move by itself? Okay, Halloween goes. And, you know, I said to him, because the Precision Medicine meeting was Engine and Tech Hall, so nice to be back on campus. I lived here when I was a student. So it is just so grateful for me to be here. I remember when this event started. So for people who don't know, I came here in 2002 as a PhD student, and stop it. And I was just very, very grateful to have a chance to live here at Mission Bay. So it's very special for me to be here, and it's very special for me to be here at this event. Before I start talking, though, I very much need to ask all of us to take a pause. We've had preventable maternal deaths this month, one in New York City at Wood Hall. And then we had 2 preventable maternal deaths because people did not want to seek care for preventable complications of abortions in Georgia. So when I think about Candy Thurman and Amber Miller, you have to say their names because these are preventable maternal deaths that could have been, like, their lives could have been saved. So I want to take a minute to honor them and charge us to do better. Okay, I may or may not get through all my slides, but y'all know me. I'm going to send them to you. You have my affirmative consent screenshot, tweet, share, record, because I think it's really important, especially since I travel the country around reproductive health rights and justice right now. People who are in states that have banned books and all sorts of other things, they are using social media, they are using YouTube, they are using publicly available tools to be able to get access to evidence and fact-based information, so you have my affirmative consent. Okay. In Seattle, Washington, where I now currently live, land acknowledgements are very important. I know we have some written here. This is the one from the UCSF site. I think it's very important we acknowledge the land that we're on. One thing that the Native Indigenous people and the Black people in Seattle have taught me is there's a labor acknowledgement that we need to have as well, which I think is really important. I'm going to read this one because this one's very important to me. I acknowledge that the United States was built off the exploited labor of kidnapped African people. Much of what we know about this country today, including its culture, economic growth, and development throughout history and across time, have been made possible by the labor of enslaved Africans and their ascendants, who suffered the horrors of the transatlantic trafficking of their people, chattel slavery, and Jim Crow. Very, very important. Okay. In this room, this will look very familiar to many of you. Many of you who I like, admire, respect, contributed a lot of data to make this known to many scientific communities, right? That where we live, play, pray, thrive, all the things that we do that contribute to health has nothing to do with what we do clinically. 0, right? Maybe 20%. And that's including genetic predisposition, right? But that there's this whole other milieu, there's this whole other environment, there's a whole other thing that impacts health, right? Because last time I checked, human beings are not immortal. None of us are getting out of this alive, right? So we want to really think about what are those other factors that impact health. Okay? I like to look at it this way. So how many people in the room know what social determinants of health are? Right? Okay. How many people know that social determinants of health are neutral? They're not negative, not inherently, right? If you really think about it, the social determinants of health, having a safe, affordable housing, living wage, quality education, transportation, availability of food, job security, those are not inherently negative. It's the lack of not having those things. That's the problem, right? And how many people in the room know that social determinants of health are policy decisions, right? Social determinants of health, we got a pointer on here. Is this a situation? Let's see. All looking at, okay. Social determinants of health don't fall out the sky. I spent a lot of time when I was here, me and Howard Penderhughes used to talk with the students about this all the time. Yeah, that social determinants of health are not, they don't fall out the sky. They're not imaginary, like they're not like made up, right? They are a result of this layer, right? So, and this comes from a very old citation in 2010, but I think it's still very relevant. So if you want to understand why we have disparities in illness and wellness and health in a society, right? What you want to look at is, well, where do these come from? Okay, we got to look at your labor markets, housing policy, education, schools, social safety net, all these things. These are all determinants or predictors or creators of social determinants, right? Well, where do these come from? Well, the way I think about it is you either have structural or institutional racism, you have class oppression, and then you have gender discrimination or gender exploitation, right? Sexism, patriarchy, right? Homophobia, transphobia, all the different phobias. That's where all that comes from. Because otherwise, we have enough human space, money, time, and reputational resources, if we wanted to be able to make sure that everybody had all these things, right? Is there anybody in the room that, besides me, that believes this? Okay, I see some heads. We're doing a call response. Y'all know me, right? So we're going to do a call response. We want to make sure, because I'm standing between y'all and lunch. And see. Okay. All right. Too many people historically have talked about constructs and not defined them, and that has driven me up a tree forever. It started when I was here in the labs, and yes, I'm a laboratory trained person, I'm dragged them too. But having definitions matters. And why? So that we all can get on the same page about where we're going and what the strategy is. So I would be remiss, this is the 30-year anniversary of reproductive justice. What drives me up a tree, because you even have reproductive justice coming up in presidential and vice presidential debates, right? We've been doing a lot of awareness raising to get people to understand there was always a different way that we could talk about abortion, family planning, contraception, and infertility, surrogacy. There was always another way to talk about these things. And that was conceptualized by 12 Black women, right, in 1994. How many people know all but one of these folks are still alive, right? Dr. Evelyn Field, who was an educator in Maryland, is the only one that's no longer living, right? I had the opportunity to see the mothers, the founding mothers of reproductive justice. I mean, Loretta Ross is a MacArthur Genius Award winner, y'all, right? She's currently a visiting professor in the School of Nursing at Yale, because my former dean at UW is now the dean at Yale, and she invited her and Daniel Dawes, right, to come because they are trying to be really serious about institutional transformation, right? These are the founding mothers of reproductive justice. I got to sit with them in June, just a couple of people in here in this room that was there with me, right, to talk with them about why did they conceptualize, reproductive health and social justice together. Why did that matter in 1994 to talk differently, to create a different conversation? Because they predicted where we would be right now if we continue to allow for a single story, a single narrative to drive the complexity of what it means to be a pregnant, capable person in the United States. They understood the complicated narratives around capitalism, sexism, patriarchy, and they saw where we were going. They predicted Project 2020, when people were still around, specific to TANF. How many people remember that? The temporary aid for needy families, welfare reform. Remember those discussions that we were having? So, reproductive justice. Well, reproductive rights is a framework, legal framework that citizens should expect the protections, right? Because last time I checked, we were all sentient beings who have bodily autonomy, and we need legal protections as citizens in order to be able to operationalize our futures. Okay, that's reproductive rights. Reproductive health is reproductive health services provision. You're going to walk into an exam room, you're going to get a testicular exam, breast exam, pap smear, whatever. That's health care, health services provision. Reproductive justice is a transformative way, a theory, a praxis, a organizing strategy tool to be able to reject false definitions. And the way that RJ people talk about this, you have a right to have children, to not have children, to parent the children that you have in healthy environments without fear from violence from any individual, government, or state. And then I always add on, and you have the right to disassociate sex from reproduction, so we can have conversations about consent, healthy sexuality, pleasure, as being a part of a whole human life. That's real different than pro-choice and pro-life, right? Which is lazy and a shortcut, right? So we all can admit problems, but then we can behave differently in order to rectify them. We got sold a lie, and it needs to be called out as such. Okay. Just said all that, right? RJ people also really believe that these movements have to be led and conceptualized by Black, Latinx, Indigenous, and women and other people of color. Because clearly what we've been doing is not working, right? Okay. Let me define some things. I've been spending a lot of time, and I want to thank Peng. He's a really great partner when I was here trying to really think through what anti-racism should look like in the throes after George Floyd's murder, after Breonna Taylor's death, right? We were trying to really wrestle with what does it mean for an anchor institution to try and leverage its tools, its skills, its knowledge to bring us to a more just future. So thinking deeply, I love Dr. Ellet. Dr. Ellet is a Black woman trans scholar who's at Penn. She's finishing her medical education. She did her PhD in biostatistics first, because overachiever. I love her. She's one of my favorite people in the world. And in fact, she was my social media editor at Health Equity until 3 months ago. And now she's just moved back to the editorial advisory board because she's interviewing for a residency. She defines anti-racism as the continual practice. You see the action in that word, right? The continual practice of unlearning internalized belief systems dictated by white supremacy, redistributing power, resources, and privilege to populations directly and disproportionately harmed by white supremacy, and redressing historical and contemporary biological, mental, spiritual, and social injustices enacted under white supremacy. The thing I love about this definition, it puts the blame on the blame me, right? But there's so many active verbs. I tried to underline as many of them as I can. There's a lot in that single sentence, right? But that's really what we're trying to do, or at least that's what I'm trying to do, okay? One of the things I write all the time, it drives me up a tree as a journal editor-in-chief of Health Equity, is people don't tell me what definition of health equity they're using. And they look at me like, wait, what? And I'm like, what do you mean when you say health equity, right? I'll give you a perfect example of this. I was reading a paper, and it was about diabetes. And I'm like, okay, what is diabetes in the context of health equity? What, we all have diabetes or nobody has it? Like, that doesn't make any sense, right? So we have to stop being so scientifically lazy and not really defining things. When Kamara Jones was here as our visiting professor, when I was still here, she had coined a beautiful, parsimonious definition of health equity, right? It is the assurance of the condition of optimal health for all people. Does anybody disagree with that in here? Raise your hand, right? That makes sense, right? We are looking to curate the optimal conditions for people to have great health. I actually have been very disturbed by, I love Ryan Pettaway. He's a public health scholar at OSHU and Portland State University. I just love him. His brain is amazing. He blew my mind when he told me that health equity was not going to be achieved. It was going to be experienced. And I was like, experienced by who? And how do we measure that? And when? And is that dynamic? And why did you say that out loud? And oh my, I love you. He blew my mind with that, but think about it though, right? If we're trying to, if the universe is dynamic, if racism is dynamic, if human beings are complicated, then that means that we won't, how will we even know when we've created the optimal conditions for people? So anyway, but it made me think, because then he finished the sentence. We have to set, that doesn't stop us from setting ambitious goals for the health of all humans. to be able to work together to realize the trajectories that people need in order to be healthy. Right? I was like, okay, that's better. Birth equity. My good friend, Dr. Joya Creer-Perry, who I love and started the National Birth Equity Collaborative, I still do a ton of work with her. She and Kamara Jones are really good friends, and she created a definition of birth equity, right? This assurance of all conditions of optimal births for all people with a willingness to address racial and social inequalities in a sustained effort, right? Birth equity is really different than saying forced birth because we're going to ban abortion around the country, right? Or that we're not going to allow you to be able to access infertility treatments or assisted reproductive technologies because you either haven't earned them, you're not worthy of them, or you can't afford them. It's mean, that's cruel. We need to call that kind of stuff out publicly. I've been working on so the National Academies of Science, Engineering, and Medicine propped up the first ever standing committee on reproductive health equity in society. And I'm the only nurse that's on the founding committee. It's very irritating. But we don't even have a definition of reproductive health equity, so I took a crack at one. And so reproductive health equity, borrowing and building off of Kamara Jones's definition, and borrowing and building off of Dr. Joy Creer-Perry's definition, is that it's the assurance of the conditions of optimal health for all people, which is a direct quote from Kamara Jones, but that we're using reproductive justice as the mechanism to ensure whatever trajectory individuals envision for themselves in their lives, right? How many people can get down with that definition? Right. And I had to add the second part because the onus, the only true arbiter of any health risk, we wrote this in the amicus brief around Dobbs, the only arbiter, the only person that can really make any decision, reproductive decision, has to be the pregnant, capable person. You are creating a relationship with two other human beings for the rest of your life, right? One with whoever the co-parent is and one with whoever the offspring is, right? And people ask me why I'm a childless cat lady. I don't trust nobody like that. I can't have no lifetime commitment to somebody. Come on. People who do that are courageous and brave because y'all trust in the future that you're still gonna like that person or those people. I have issues. And I can't have somebody else telling me that, though, right? When I have a Black maternal health crisis in the United States where Black women are 3 to 4 times more likely to die from preventable pregnancy-related childbirths, you gonna tell me that that's a risk I have to take on? How about no, right? That's a real different conversation than saying abortion is murder or abortion is not healthcare, right? But we need courage, we need brilliance, we need wisdom, we need political will to have different conversations with different constituencies at different times. Okay. Conceptually, I'm a picture person, so let's talk about this different. Some of you have heard me talk about this. This is really important because I get really irritated when I'm in the middle of a conversation with people and I realize we're having 3 different conversations and we all not use the same words, but we're all not having the same conversation. I published this in the Journal of Perinatal Nursing. It's behind a firewall right now, but if you email me or hit me on socials, I'll send you the PDF, right? It's a real simple framework to get everybody all on the same page. Number 1, these come straight out of the Merriam-Webster dictionary. So if you need your break and it's time for you to go to the bathroom, you can look these up later on your own, okay? To retrofit something means to adapt it to a new purpose or to modify it. Right? We had to retrofit buildings and campus and tear down the school of nursing because the earthquake safety. Retrofit, right? Okay. There are 4 definitions of reform in the dictionary. I like the first one because the first one allows for you to remove something, right? You're going to change something into an improved or a different condition, a different kind of form, but you can remove something, right? When I was at San Francisco Zuckerberg, San Francisco General, when we moved to electronic medical record, we were still using paper charts. And I was like, when we getting rid of paper, right? You get to remove something when you're reforming something, which is really different than when you're retrofitting it, because the original structure is not going to change, right? The way that I try to explain this to students, when you're trying to retrofit something, if the original structure is not going to change, the number one thing we've heard in this room today that's actually really not going to change is access and insurance in the United States until we get some other way to pay for healthcare. right? So everything else, that's all a retrofit. Because until we change how we pay for healthcare in the United States, everything is either going to be driven by insurance or some, pseudo version of insurance. That's a retrofit. Any discussion we have about healthcare payment reform is a retrofit. It's not a reform, right? Because if we was going to have a reform, then we talk about single payer. We would talk. A lot of us like to sit and reimagine. How many are reimaginers in here? Y'all want to burn it down, blow it up. It all could be different. Let's get rid of it all. We'll start anew, right? What's the problem with reimagine? What's the problem? Anybody know? Say it, girl. Well, not only is it unrealistic, this is the dream space with no accountability. You can sit here all day and be dreaming up stuff that's not even possible. And then you walk away and you feel good. You're like, yes, we did that. I'll be like, okay, do you, right? This is one, and the other thing about reimagine, we need this. It's a need, it's important. The problem with retrofit, reform, and reimagine is it's a circle, it's not linear, and everybody all can't be in the same bucket, because if everybody is reimagining, we ain't getting nothing done. The other problem is you cannot burn it all down until we get our people out, right? I mean, I would love to be on Team Burn It All Down. I would love to make the Supreme Court of the United States go away. I really would. And my dad is a judge, y'all. I mean, so I would, but right now, they are holding the protections of citizens, right? So until we build something else, until the reimaginers can come up with something else, I say this to young students all the time too, right? Well, yeah, we can go into that. I was like, y'all do, we still in the now, we got to get y'all out of school. You burned out. So I know that's really uncomfortable. People don't really like that, but we need retrofitters, we need reformers, and we need reimaginers, and everybody all can't be in the same domain, because if you are, then we're going to keep sitting here frustrated with no action, no motion. We have no play space where we can all bring all the different ideas together to change the future. Because this is the other inconvenient truth that nobody wants to talk about, but I'm going to say it because I'm Monica, right? And that is every decision we make in the now changes the future. So make the courageous one right now. One could think about retrofit, reform, and reimagine. Reproductive health is retrofit, right? Because people are going to live, people are going to die, and all people really want is a dignified life or a dignified death, right? So that's a retrofit. Reproductive rights, the law. Okay, so we saw for 24 hours, the 6-week ban in Georgia against abortion was lifted, but then they brought it back, right? That's a reform. We're trying. Until we have a better system, different people, different judges vote, right? That's not changing. Reimagining reproductive justice, we can bring, this is the hearts and mind conversation right here. We can reject every lie we've been told, and we can create new conversations with people to get them to understand the humanness that we all share, right? Collective impact. I try to say this to people all the time. If I had a magic wand and I could change the future and change the world, don't y'all think I would have done it already? Right? As much I wish, some stuff I just wish I could just do, but I can't because it requires a collective impact. But a collective impact also requires that people will act. Not convene, not meet, not chat, action, right? And that's very important. So if we was gonna retrofit something in reproductive health, rights, and justice, and we were really thinking about anti-racism and health equity and all these really good things, I wrote this when I was here on lockdown during my sabbatical. I published 20 papers in 2020, which, whatever. I stand by every word of this. And anybody, if you can't see this in the back, I wrote this on March 26th of 2020. This was a day after New York City had decided that they were no longer going to allow accompaniment for birthing people to come into the hospitals because they were having their COVID surge and people were dying in the thousands, right? Y'all remember those dark days. Let's not let that go. And one of the most important things about writing this was people forget that pregnancy and childbirth is the #1 reason why people come into hospitals and healthcare institutions in the United States, because we have 4 million births per year, right? Our incidence is higher than any other disease. Prevalence is higher in cancer, diabetes, heart disease, all that. But every year we have about 4 million births in the United States. Number one reason why people come into hospitals and healthcare institutions. And so you're going to tell me that during a global pandemic, when people are dying all over the world, you got people courageous enough to birth and propagate our species, that they have to come into a hospital alone? Really? That was the best we had. I got up on calls for weeks with the United Nations, the World Health Organization, trying to figure out the auxiliary maternity units. How do you think we came up with the drive-through baby showers, right? Trying to emulate our homeless colleagues, like Margot Cushell and the folks here with Project Room Key. Can we get the hotels to allow us to turn some floors into birthing spaces so that people don't have to go to hospitals alone? And reserve all that critical care space for the people who needed it, who had COVID? Can't we think differently and fund differently? And then you saw Centers for Medicaid and Medicare Services, they finally was going to pay for telehealth and at the same rate as in-person visit. We had a moment. We had a moment. I want to create another moment, but I stand by every word. There was no reason to abandon pregnant people. Right? This should be a no. I'm tired of screaming about this. We are not supporting, we say we care about families, we say we care about, the propagation of our species, we say we care about children, we say we care about all these things, and we can't even keep people alive in the postpartum period, where 65% of the maternal deaths happen in the United States. I was on with the Surgeon General when I was sitting outside. Many of y'all saw me out there talking to Diana Ramos, right? Because they have a new project that they're rolling out. California has the lowest maternal morbidity and mortality rate in the United States, right? Which is great. However, we have the exact same racial and ethnic disparities that the rest of the country has. It is Black, Pacific Islander, Latina people dying of preventable deaths during pregnancy and childbirth. We still have work to do. And when 65% of people are dying in the postpartum period, we need to do something about that. And it can't just be a 6-week visit, right? It can't just be show up for your kids' vaccines and, we put our eyes on you and now you're okay. We have innovative models, creativities that we can unlock that can be both a retrofit and a reimagine. But again, we have to decide that that's the important work that we need to do. If we was going to reform something, this is the piece that Dean Lucey referred to that I published in Scientific American. It's a data visualization project. You can see it for free in perpetuity if you go to the Black Mamas Matter Alliance website and click under resources. It's one of the most beautiful pieces I've ever done. I have a new piece coming out in Nature next week. I'm so excited. But I purposefully put the forever link behind the Black Mamas Matter Alliance website because I wanted people to have to go through Black women to read about how to fix maternal morbidity and mortality. Right? There's a method to all of my madnesses. This one, Amy Allspaw, who was she's currently a professor at the University of Kentucky and University of Tennessee, Knoxville. She was a midwife PhD here with us with the Actions program. She led this scientific piece, which is actually in social science and medicine. And then the accompanying public-facing piece explaining our research findings in Scientific American. Right? One of the reasons why we're losing the science communication battle is because we're not using the tools that we're so resistant or afraid of. I told the Surgeon General this morning, I said, one of the things that we screwed up during COVID, I've said this forever, we should have done 15 minutes on Fridays with Fauci on Instagram Live with influencers, answering questions about COVID. How many people remember the 4 o'clock George Rutherford epi calls on Zoom? You were sitting in your kitchen, just like I was, dying to see what the case positivity rates were and to see his charts, right? How many people in this room remember that? Every Friday, 4 o'clock, right? So if we as science communicators, if we as educators, if we as policy folks want to be able to change the conversation, That means we have to reform how we talk about our work, and we have to reform how we teach learners how to explain their work, right? I published Ryan Pettaway's poem in Health Equity because it conveyed the very specifics of youth violence prevention, building off of Howard Penderhuse's work. That was amazing. We have to start thinking very, very differently about science communication if we actually want to win the battle against misinformation and disinformation. And unless we just want to keep talking to each other. Because some people, seriously, some people are retrofitters. They think it's really important that science communication is us talking to each other. That's where you're having different conversations with people and you don't know it. If we were to reimagine something, this is from one of our graduates, Dr. Irene Martinez, and you all know I'm a big fan of our sociology PhD program that sits in the School of Nursing. She's in, I think, UConn. She wrote this entire incredible paper about how do you work with community members to do participatory budgeting, sharing power when you're writing not just the grant, but the budget. What are the principles, the core guidelines around that, right? And, you know, our team at the Preterm Birth Initiative, we had data use agreements that the community members came up with. Why are you using our data? What purposes? And people had to come to the Community Advisory Board and explain, thank you, Chanel, in the back, pulling this out with Dr. Brittany Chambers, right? Communities got to say what data got used and for what and why. We need to be engaged, right? I mean, we keep creating experts by education. That's what we are. But we have experts by experience in the room, people with lived experience. And then we have the most under-tapped resource in anti-racism and health equity, and that's the experts by employment. That's the staff, right? So we need to bring the 3 E's together, the experts by education, the experts by experience, the community members, and the experts by employment, our staff, together. That's when we would get secret sauce and we can start reimagining, because then we're all having the same conversation. So here's another way to think about this. I was at a journal editors meeting in New York City in June because we are creating, and actually it should not be embargoed next week, we have a toolkit and a guideline on how to conduct an anti-racism health equity review. We're done with the race science being published. We're done with harm occurring in our scientific record. There's a reason that the incredibly badass team here at ANSWER, Advancing New Standards in Reproductive Health, were key in the retracted science. We had retracted science in the Dobbs case, right? In the Supreme Court case. Flawed methodology. Something broke in the peer review, and the editors that allowed for flawed science to make its way to cases in the Supreme Court that ultimately would turn on the row, right? So clearly, we need to do the retrofit of academic publishing, not just the funding models and not just fighting with the publishers, but the actual content of what gets published. Why, by whom? Have we had cultural rigor and community review? Because I can tell you right now, one of the most exciting things I'm doing, I was at Robert Wood Johnson in New Orleans, because they are about to fund journals who want to provide anti-racism and health equity training. They are building off of the work that we did here at the Preterm Birth Initiative, and they are going to allow us to pay community members $125 an hour for orientation and to be able to review 200-word lay abstract summaries that will be required by authors who are publishing with Health Equity and Mary Liebert, so that the community members can conduct their lay review of that abstract. And then we're going to put that with the blind scientific peer review. And then the editor-in-chief, that would be me, is going to weigh those and make a decision about whether or not that science should be published. Right? If we're real serious about including community voice in scientific publication, then we will pay them as a brand new paraprofessional set of people. We will compensate them for their expertise by experience. We will add cultural rigor to our science, right? And we will add a structural layer, and this will be a national advisory board, and if we can get this through and iron everything out at Health Equity, Mary Liebert has said, as my publisher, that they will roll this out to all of their journals. They have 100 journals. They're already doing this in their autism journal because they have to, right? Because the parents and the autistic adults need to read through that science to be able to make sure that it's accessible, right? So we have ways of changing the future in the decisions that we make now if we have the courage to do so, right? This is a book I published a chapter in 2020, right? I want to talk to you about why workforce diversification is so important to reparations, to reproductive justice. People act like we have different populations of folks, right? Our students are reproductive age. We just heard a fabulous panel about the new high school program that's coming through. We got high school students here. I'm so excited about that, right? They're now growing up in a future where the protections for half the population of citizens is banned. So we have to think through, like, these are the people that we want to educate to be our future knowledge producers, our scientists, our scholars, our clinicians, even our staff. Like, we have to understand that they have yet to operationalize their own reproductive trajectory yet. So if we're not putting things into place to retrofit or reform to allow for them to envision their lives the way they want it, then we're not working towards reproductive justice. So in my mind, the way this all works is if we wanted to, again, using the retrofit, reform, and reimagine framework, one could say that the future workforce people are retrofit, right? We want to diversify our faculty, we want to diversify our students, we want to diversify our staff. That's the retrofit is people. Place, and I'm, child of the 80s, right? People, place, the thing, y'all remember Schoolhouse Rock, right? They had a little song. Okay. Community engagement, place, that's the reform. And we've done a lot of work here to make sure that communities are engaged, involved, led, driven, right? Those are words we should be moving towards. Because I like community engagement, but I actually prefer community co-led. I like community driven. That's the way I'm at in my research program. But the reimagine is things, community investment. And that's what this sort of high school piece is, right? You think about we need to make investments now, because in the future, it won't be intimidating or overwhelming for somebody to come to UCSF because they were here as a high school student, right? So if we really want to get to reproductive health equity, if we really want to get to health and well-being, if we want to get to sustainability, if we want to change the future, if we want a new world, we have to start building it now. I think too many people, though, right now are dishonest, and they're not saying that actually what they really want is a legacy for the work that they've already done. I know, ouch. But somebody had to say it, right? And don't get me wrong, that's important. No, I don't want to see people get erased. No, I don't want to see good work being dismantled. But history has a way of telling truth or multiple truths. And so I think us wasting our time on legacy is not helpful. And quite frankly, I think it's a coward's move. And I think we can unleash creativity in a better and different way. So I'm gonna stop here. How much time? Who am I supposed to be talking to? Okay, am I good? Am I out of time? We good? I got 7 minutes. I'm looking for questions, comments, suggestions, feedback, discussion, because I hope that I've done the one learning objective that I have for this talk, right? I wanted to excite you, activate you, remind you that even though our times are very uncertain, and in many places they feel very grim. We've seen the walk back of equity and diversity inclusion. We've seen cowards scour and dismantle all of their C-suite offices around this work. I mean, let's call the thing a thing, right? And we worry about how are we going to continue to do this work in a context where we're banning books, we can't talk about certain things, different academic majors are being, removed from different institutions. Some institutions that have power refuse to wield it. I talked about this on Instagram, the decision of my father's alma mater, Peng, to no longer make public statements. That's a choice. That's a decision to say that you're not going to do something like that, right? So when I think about where we are in this current moment, I want us to collectively imagine or reimagine, regardless of what happens, on November 5th, regardless of what happens, on January 20th, what are we doing in the now that will help us to change the future? And that's why symposia like this are so important. We've seen burgeoning science from scholars, from learners, from trainees, from current faculty that make me really, really excited that our knowledge production is really going to be not only grounded in rigor that is scientific, but rigor that is also part of a very important culture. Is that helpful? What y'all got? Oh, and tell me your name and tell me your pronouns, and I'll take comments, questions, suggestions, feedback.
Raise your hand.
Oh, I see some OB/GYN colleagues in the middle.
Hi, Monica. Thanks for a great presentation. I'm Bimla Schwartz. I use she, her pronouns. And I really loved your recommendation to focus on definitions. And I wanted to ask you to go a little bit further with that, as one of the challenges I've been chewing a lot on is how do we communicate effectively with community members whose language that is most familiar to them may be misleading. So for example, we talk about having your tubes tied, and people understand that, and then they misunderstand that that would be an easily reversible, just untie that bow. Mm-hmm. And we talk about permanent contraception instead of sterilization, all bad terms. Like, I think I'm moving myself to talking about surgical contraception, but wanted to get your thoughts on how do we balance this familiar term, but term that's taken you where I don't actually want you to go with your understanding.
Thank you so much, Bimla, for the question. We've been known to each other for a very long time, so it's really good to see you in person. So this is where I would say two things. Number one, this is where 15 minutes with contraception person, I think Ashley Jelanius from OB/GYN did this really, really well, demystifying things on TikTok. I think being able to just say that. We don't have really good language for what I'm about to talk about. Here's what it's been called, or having infographics around this also would be helpful, right? But from a science perspective, I think having some community, either focus groups or a photo voice, around what words would they like to use. See, here's the other thing that I've learned as a researcher, and I learned this here, is that I don't have to figure this out, right? If we do enough research prioritization, if we do enough community listening, if we bring them in as our partners, we actually don't have to figure out what the right language actually is. It is our job to set the table and say, these are the different things this has been called. This is vasectomy, this is tubal ligation, this is this, right? And in that research question, to be able to say, is there a better phrase that we can use? Is there a better way that we can say this that will resonate with you? Or what do y'all call this in your own culture, language, whatever? And then make a determination about, can we create a structure that would allow for us to know we're all talking about the same thing, but we might be using different words. That's how I think about it. And Blair Imani also is an Instagram influencer. She does how to be smarter. She does these like 30-second, here's what, being a bisexual is. Here's what contraception is. Here's what colorism is. Here's what da-da-da-da is. I think we are underutilizing the current tools. I think too many people are holding on to the vestiges of what we think actual scientific tools are. And I think we need to start to disrupt that mindset. One of my mentors, Dr. Diana Mason, who does strategic comms, one of the things she talked about quite a bit is this podcasting thing. I mean, I think we've underused scientific podcasts. That could be a beautiful place to allow for community members also to provide us some input on what should we be calling these things? Or what would resonate with you around this set of decisions? The other thing we want to do is decouple, like receiving information from community members and then providing clinical care. I actually think the older I get, the more I'm starting to really think about that counseling and information sharing and health education actually needs to be a thing in and of itself, right? And it does. And I get why we tie it to clinical interactions. I get why that happens, but I actually think that whole thing needs to be reimagined, because that's where we're missing the opportunity. That's where people feel stretched. That's where people don't have enough time. That's where harm occurs. And so for me, as a harm reduction strategy, I actually think we need to decouple health education from clinical services provision. Other thoughts, questions, comments?
My name is Grace Kistner, she, her, L. And I wish we could have asked our question together, because I wanted to know if you had additional thoughts on extending that answer to discuss how we go forward equitably with giving clear definitions to have the same conversation, but how that is different from labeling.
Well, that's a really important distinction. It's kind of like when I always try to talk to people about the difference between presence and attention. So labeling is things that we do in research because we're trying to categorize, describe, or discover something, right? And so I think, again, you get this overlap, or you get this blurring of the lines when you have one thing that's developed in an entity, and you have but then you have it being utilized in that same environment. And so by decoupling those things, I think we might actually get to a place, and maybe it's just because I clinically grew up at the General. And the Women's Option Center at the General does this really, really well, right? Because we have very distinct partnerships and synergies in terms of roles, whether it's the counselor or the nurse or the physician or the fellow or the anesthesia. Look, there's a very beautiful machinery and model that I have pushed them for years to write up as to why that works. And it's all in this sort of umbrella of patient, like their whole experience. We all bought into this notion that people may be here a long time, but they're going to have a comprehensive experience that is not going to be harmful. So, I'm going to think a little bit more about this, and I'll have to get your contact information, because I do think the labeling serves a purpose when research is the intent. I don't think labeling is helpful when we're trying to convey information. That may be a very nuanced distinction, but the way that I think about it is I don't want labeling to be somehow made a negative construct, because it serves an essential purpose within the context of research, and we cannot have harmful labels. But from an equity perspective, I always feel like if community members are not helping us to figure this out, then at some point they need to be helping us to figure this out, because otherwise we will go down the road of harm. See you in the back.
Hi.
Hey.
My name is Natasha, and I use she, her pronouns. I work in the emergency room here at Mission Bay. I've been an emergency room nurse for a very long time, well, more than 10 years. And what I've seen in this field, especially in nursing, is it's pretty diverse. This was the first time I joined a team where I was the only Asian nurse in the department, only Filipina nurse. And as it stands, I think I'm the only one on day shift. And I am the DEI lead at the department. What I'm having issues with are a lot of getting people engaged. I see that people are like, yes, health equity, I care about this. Anti-racism, I care about this. But the same 5 people are coming to my meetings, or coming to the meetings. And I will try to gather people, and I hear chatter and I hear a lot of passion. But when it comes down to what we're trying to do, it's the same 5. It's the same 5. Maybe
the ones that need to be there are never there.
That part.
Let's get on that.
That part.
Okay, well, first of all, I have to do my superpower. I don't know if you know this or not, but Dr. Ana Valdez, sorry to put you on the spot. my best friend, but Dr. Ana Valdez is here. She is the dean of Sonoma State University. She also happens to be the journal editor for the Journal of the Emergency Nurses Association. And she's been an emergency room nurse for a very long time, and y'all should connect. So, coalition of the willing. Keith Yamamoto and I talked about this. How do you build a coalition of the willing where it's not always the same people trying to do the work? How do you bring along the people who don't either believe in the work, don't want to do it, they might have interest, but they don't know what to do, right? And so for me, I always spend a lot of time recognizing that that's probably the 15th or the 16th meeting. That's actually not, there's no way to bring into active anti-racism and health equity work people who don't want to do it on day one, but you can get them on on the 15th attempt. So here's how I do it. The first thing I always do is in regular staff meetings, I have to expose people to content, whether they want it or not, because you got to be at the staff meeting. Right? So at the things that are already mandatory or things that people already buy into, like right now I'm doing this at UW at the faculty meetings because a lot of the people that I can't get to come to equity, diversity, and inclusion activities, we have one of the most premier internationally recognized anti-racism scholars, Dr. Crystal Fleming, who used to be at CUNY in New York, Stony Brook, who is now at Smith College. She is in residence with us to work on how do you create an anti-racist syllabi. Right? The people whose classes are most racist that reify race science are not at our sessions, right? So I invited Dr. Fleming to the faculty meeting where they actually come to, right? In the same way we say we have to meet patients where they are, we have to meet community where they are, we got to meet our colleagues where they are, right? So I'm looking for other places where those faculty that I really want to reach, even if I can get them a nugget somewhere, then I'm going to make sure that Dr. Fleming and her words and her work they're going to have some kind of exposure. The second layer that I do is I make sure that we don't remove those people just because they don't participate. They still got to get the same emails, they still got to get the same materials, they still got to get the same flyers, all of those different pieces. Then we try to incentivize that work. We actually are piloting, and boy, did this have to get to the president and the provost, course buyout for the known offenders of people who are harmful in the classroom to participate in Dr. Fleming's seminars. We gave them a class of time back for them to be able to engage and participate in volunteer activities to work on this. So sometimes you got to get real creative with people. The other thing is we've empowered the staff that work on those teams. Again, this is why we cannot do this work by ourselves. As faculty, you can't do it by yourself. As community, you can't do it by yourself. As employees, the whole staff are now parroting back things that they've learned. We've included them in our anti-racism training and work of how to create an anti-racist syllabi, and the ed tech people. That's the other thing. We've included modules. We have a textbook project where people can report any externally created biased materials, whether it's fat phobia, homophobia, whether it's racism in our textbooks. We met with Wolster Kluers and Elsevier because they were like, oh, we heard you have a database of harmful material. I was like, yep, we've been having our students and faculty report that material. Got a grant from Robert Wood Johnson to do that work. And they're like, oh, well, will you do a cultural review for our next version of the book? I said, only if you're going to fund one of our adjuncts to do it, right? So in my mind, we may not get those faculty who the students complain about and who continue to teach race science on the first, second, or the third try, but somewhere we're going to find something they really care about on campus to be able, and one of the last nugget of incentivization that we're going to use at UW, because we're on 9-month contracts, we're going to pay people summer salary to come in to participate in anti-racism and equity activities because we have the budget to be able to do that. So sometimes you have to bring people along and recognize it's a long haul, but then having those tools and that administrative and leadership support to know that that's the goal, right? Not to continue to have the same 5 people sitting around talking to each other, but to actually really, where are the places where you can bring along folks and where are the incentives? And then at some point we are gonna have to get to the sticks, right? But we're not leading with that. We're really trying to bring people along in ways in existing structures that are already functional. Okay, hi, tell me your name, tell me your pronoun. I still can't hear you.
This is Merdad, he, him. Thank you for the fabulous talk. I really loved it. Because you're such a fabulous philosopher, I would want to critique the word optimal health, which is similar to the definition used in WHO, which is a state of complete physical, mental, and social well-being. I would beg to differ because there is no such a thing as optimal or complete. We do have best available or gold standard, which is something normative, but optimal is work in progress. Thank you.
No, I appreciate the feedback. And we wrestle with this, right? I mean, optimal, we also try not to use ableist language, right? And so it's kind of tricky to know what these are. That's why I had draft on there, because I actually think we need to wrestle with the language of these definitions. So thank you for that offering, because I actually really do like best available. And I do like the WHO's definition. As an editor-in-chief, when I send out, there are about 6 different definitions of health equity, all on a PDF form that I send out to potential future authors to allow for them to choose the one that resonates best with them. I just personally happen to like Kamara Jones's version because I think it works for the kind of work that I do. But you're right in the sense that optimal is a tricky word and that we want to think about what that means in different contexts. So thank you for that. Thank you. I am sorry, but we're out of time. I'm gonna be around.